Rheumatoid arthritis. You may know that it's actually a chronic disease and it's a systemic problem, that it does not primarily affect the knee joint, it can affect any joint of our body. But when we are talking about problems with the in the lower limb, the main affectee is usually the knee joint. Although this is a chronic systemic autoimmune disorder which can affect multiple other joints of our body, especially the hand. In the hand, it involves metacarpophalangeal joint, proximal interphalangeal joint, as well as the wrist joint mainly. Although it can involve elbow as well as the cervical spondylitis may be also be caused by the rheumatoid arthritis as well. And then when it comes to the lower limb, as we are talking about the lower limb, usually knee joint is affected more than the hip and the ankle joint. Now, rheumatoid arthritis has, it's basically a systemic autoimmune disorder in which the body starts to produce certain cells and immunoglobulins actually, which are creating problems for the body's own cell. Mainly the factor which is produced is actually the rheumatoid factor, which is an IgG antibody. And usually the cells which are mostly involved are actually the mononuclear cells, which are the most notorious for this autoimmune reaction against our own body. It starts with affecting the soft tissue, which is actually the synovial tissue. Synovial proliferation starts to occur, and initially the soft tissue is affected. Then comes a stage of articular destruction in which the cartilage is actually destroyed gradually with the death of chondrocytes, and once that has happened, then it starts to attack the bones. And when you're talking about how this whole pathophysiology starts to happen, actually is that antigen antibody reaction occurs or antibody reaction occurs. Now, rheumatic factor may be produced by certain cells, which is mainly the mononuclear cells, or mainly the cells which are producing that. And once they start producing it, this antigen antibody reaction leads to further proliferation of these cells and further production of this antigen antibody complex. Now, once this happens, this starts to actually occupy the receptors on the normal cells, especially cells of the joint, and which are lining the synovial membrane, that is the synoviocytes. Once this starts to attach on the receptor of the synovium cells, this leads to proliferation and hypervascularity of the synovium, leading to a synovial pannus formation. Now, once that has happened, a synovial pannus formation is when the early stage or early changes of the rheumatoid arthritis starts to appear clinically as well as symptomatically. Sometimes the patient may remain asymptomatic for quite a long time, but once this changes starts to reach a point where they start to become symptomatic, is usually a synovial pannus formation has already occurred, and this leads to then further the next stage is actually the death of chondrocytes and destruction of cartilage. Once that happens, this is already a midway through, and from then the delayed changes or end stage changes starts to appear, that is the bony changes, the periarticular erosions, periarticular osteopenia, problems with the bone and aberration of the bone. All this occurs at a very end stage. Usually initially it's more of a soft tissue swelling and soft tissue problem, which starts with soft tissue, goes to cartilage, and eventually goes to affect the bony structures. So early stage, it may be very like synovitis. Why synovitis? Because antigen antibody reaction has occurred. These complexes starts to stick to the receptors of synoviocytes, which are actually present around the synovial membrane. They starts to proliferate, leading to synovial proliferation and synovitis. And synovitis and hypervascularity is actually the very early signs that the rheumatoid arthritis has started in the patient. Then, as this happens, because there's some degree of swelling as well as pain, and this pain is usually not severe enough, it's quite dull aching pain, which may be of a chronic sort of a disease and may be prolonged for a quite a long time. Patient may be getting along and managing pain with some other things like, for example, crepe bandaging, using certain other NSAIDs off and on as well. But pain is usually of low threshold. That's why it is at this problem time, it may not be the main problem for the patient. Then comes the swelling. Swelling is important because once the synovitis starts to happen, synovial proliferation starts to occur. This leads to hypervascularity of the knee joint. This hypervascularity eventually produces increased effusion and edema, and this leads to swelling. And swelling further starts to compromise the range of motion which is actually occurring at the knee joint. And swelling leads to effusion, and effusion actually leads to decreased range of motion, because if the knee has swollen up like a balloon, it will be difficult for the patient to actually move a knee joint. And we know that almost the movement which is occurring at the knee joint is from -10 to 130 degrees. That is that on average a patient can extend a knee joint up to 10 degrees, that is above the normal 0 degree, and then it can bend the knee, or flexion can occur up to 130 degrees. And usually they have diminished flexion as well as extension. Why? Because of the massive swelling which is actually occurring due to swelling and effusion of the knee joint. When this starts to happen, then effusion, swelling has happened, patient's natural reaction is to decrease the range of motion at the knee joint. This decreased motion eventually leads to atrophy of the muscle, plus these antibody and antigen antibody complexes are also attacking the myocytes as well. And this may also be the reason that why, because it's an autoimmune systemic disorders affecting multiple other joints and musculoskeletal system. They may be associated with increased muscular atrophy, along with to some extent there's always disuse atrophy, as well as mainly the rheumatoid arthritis is also leading to quadriceps atrophy as well. So it's kind of a mixed picture of both factors are actually contributing, and eventual result is atrophy of the muscles. Then synovial, once it becomes hypertrophic and hypervascular, sometimes this may be very much palpable as well, and this may be leading to synovial hypertrophy or hypervascularity. And then what happens? Now this is actually the process has started. There is autoimmune problem is continuing. Their synovial hypertrophy, hyperproliferation, synovitis, along with the swelling, effusion, decreased range of motion at the knee joint, and as well as atrophy. Now this is the stage which is the mainly effect is on the soft tissues, that is the muscle, tendons, ligaments. Now from this onward, the second stage will progress, that is the cartilage destruction. And when this happens, the knee cartilage and chondrocytes become dead. There is actually tenosynovitis and ligamentous inflammation as well. This leads to joint subluxation and knee becomes unstable. When the knee has become unstable, this will lead to subluxation or even dislocation as well. And there has been cases in which the patient with RA presented with a joint dislocation, but when further history was taken out, the other signs, symptoms, and criteria for the rheumatoid arthritis was also there for that patient. And then this would further lead to further muscle wasting, because now there is a disuse atrophy as well. Patient starts not to bear weight because there is always a tendency of feeling that things are going to give way, and he may lose control of the knee joint during the movement or gait. Therefore, this further leads to more destruction of the chondrocytes, cartilage destruction, more effusion, more marked swelling, and eventually further leads loss of flexion and extension. Now this is sort of a vicious cycle. When it starts from the soft tissue and synovicites, goes to cartilage, and at this point it's more aggravating, and vicious cycle is going towards end stage, that is the bony destruction. And eventually bony destruction is at very late. Usually it's all this processes by this time. Patient may be having symptoms, patient may be having problems with the gait, patient may be having problems with locking and catching and giving way of feeling as well, and there may be other joints involved as well. Usually it's highly rare that rheumatoid arthritis affects knee joint only. When it is affecting knee joint, it may be affecting some other joints in different stages as well. That is, for example, if a patient comes to you with an advanced arthritic changes due to rheumatoid arthritis in the knee joint, there may be mildly asymptomatic changes over there, or mildly symptomatic changes over the other joints of the body, for example in the hands or in the cervical spine or in the hip or even the ankle as well. Therefore, when you are assessing a patient with knee joint arthritis involving the rheumatoid arthritis, then you need to assess other joints as well, especially the hand of the patient's, wrist, metacarbophalangeal joint, and proximal interphalangeal joint. Usually, distal interphalangeal joint is spared, but they're more involved in the osteoarthritis. Or you need to assess the elbow of the patient. You need to assess the neck or cervical spine of the patient. You need to reassess hip as well as the ankle of the patient as well, because ankle arthritis and talus arthritis may be very common in rheumatoid arthritis as well, and patient may be having actually the gait disturbances and knee pain and swelling, but there may be something wrong down there as well. So whenever you see a patient, always remember that it is an autoimmune systemic disease. Therefore, do assess other musculoskeletal joints as well, and also look for the atrophy of other muscles as well. Now, once this has happened, now this is kind of a vicious cycle, leads to a late stage in which the bony destruction actually occurs. And when the bony destruction starts to occur, this leads to severe pain. Now, by this time, the pain has become severe enough for the patient to actually restrict its mobility. And patient may be, first and foremost, would be the morning stiffness, severe pain in the morning, especially when during early hours of when he or she actually wakes up. Then is the disability. Disability, as I told you, sometimes may be so severe that patient may be unable to actually get up from the bed and go to the bathroom in the morning. Why? Because there is so much swelling, stiffness, and pain in the morning that it's actually unbearable for the patient to actually walk. And you can very well imagine how that life would be when in the morning you're having a severe pain, you cannot move your arms, legs, even your hands, and above all, you cannot even go to the washroom because your knees are stiff and swollen enough that they cannot be just moved. And then you try to move them, this is associated with such a severe pain that it becomes actually impossible to even extend or flex the knee, along with the stiffness. And then the last thing is, once the cartilage is destroyed, the subchondral bone becomes exposed, and eventually this is just a cascade and end stage effect that this leads to bony destruction. And bony destruction and ankylosis may be seen eventually the end result of severe form of arthritis. But usually, this bony destruction is rarely seen. Why? Because by the time all this has happened, usually these patients undergo joint replacement surgery. But if probably 30, 40 years ago or 50 years ago, we used to have a lot of patients with end-stage bony destruction. Why? Because they did not had that time of the lot of medications were not there, lot of DMARDs which were not there available. So as a result, their rheumatoid arthritis progressed to a point where started having the end-stage disease. Usually now with the advent of DMARDs and surgeries available, this end-stage arthritis is rarely seen by the time the patient undergoes a joint replacement surgery. This is the kind of situation which can occur at the end stage. If you see this is a knee of a patient right knee going into a valgus deformity. And if you see this, you can appreciate this marked reduction of joint space. You cannot appreciate any joint space between the tibia and the femur. There's subchondral cyst and periarticular osteopenia may be seen as well, which can be visible in the tibia. Although cyst formation of subchondral bone in the rheumatoid arthritis is slightly different from the osteoarthritis, and sometimes it's very difficult just by looking at the x-ray actually to analyze whether this is osteoarthritis or it is rheumatoid arthritis. But usually in rheumatoid arthritis, there is periarticular erosions, periarticular osteopenia with no formation of osteophytes. Osteophytes, joint space narrowing, and subchondral cyst and sclerosis usually seen with the osteoarthritis. But the important point is, but sometimes the patient may eventually present with completely ankylosed knee. And ankylosed knee means that you really cannot do much about it, and it's actually stiff and stuck in one direction. So whenever you get a patient with this kind of symptoms, who has a chronic symptoms with atrophy, swelling, knee joint pain, which was initially dull, now has become severe. And then you have to actually rule out other arthritis as well. But for rheumatoid arthritis, there is a criteria especially which has to be fulfilled according to the American College of Rheumatology guidelines, that out of 7 at least 4 should be positive. What are these 4 things? Some of them are on the history, some of them are actually on the x-rays, and you have to look at for them. For example, what you have to look for is there any morning stiffness for more than 1 hour, more than 3 joints are involved or not. For example, as I told you, it's a systemic disease. When it will be coming with the knee pain, patient may having a swelling of the MCP and PAP as well. So now 3 joints are actually involved. Or is there actually RA factor is positive or not? What about the hand situation? Is there any other systemic signs and symptoms of the disease or not? And is there any other things like rheumatoid nodules as present around the elbow joint or not? Therefore, all these factors has to be factored in during the history and detailed examination as well. And then when you look at the changes, especially the X-ray EP view, you usually see is periarticle erosions, periarticle osteopenia, as well as the subchondral cyst, which can be visible over here. This is usually the picture with erosions and osteopenia, which is visible along with the reduced joint space, which is seen in the rheumatoid arthritis. Now coming to the treatment. Once we have diagnosed the patient with the treatment, there is another actually field which is called as rheumatology. Usually initially it should be actually the patient should be handed over to the department of rheumatology, because conservative management is actually dealt by them. We as an orthopedic surgeon, we actually deal with the complications of the rheumatoid arthritis. Once it has progressed to a point where the conservative management will fail, probably that is the time where we take it up. And usually nowadays with the rheumatologists practicing almost all over, there is less likely that patient with this kind of problem would straight away come to you. Usually when these patients comes to your orthopedic clinic, they have been treated for a longer time on DMARDs, and they're taking steroids and multiple other drugs. And now once the complication has developed and the above stage point where cartilage has been reduced, destroyed, there's bony erosions and problems with the bony and end stage changes, that is where the rheumatologist usually refer it to the orthopedic surgeon for some form of a surgery. But when we are talking about a disease, it starts with the conservative management. That includes anti-inflammatory and disease modifying drug. NSAIDs, COX-2 inhibitors, and DMARDs are disease modifying anti-rheumatic drugs like methotrexate, leflunomide, and multiple other as well. There was initially gold was also given, but nowadays it has mainly been replaced by drugs like corticosteroids, leflunomide, and methotrexate as well. Then there are other as well like anti-TNF alpha inhibitors, because the inflammation which starts in the rheumatoid arthritis usually results in increased production of interleukin 1, interleukin 6, and TNF alpha. So therefore anti-TNF alpha inhibitors have also a role in the DMARDs. Then anti-interleukin inhibitors as well, like interleukin 1 inhibitors as well as interleukin 6 inhibitors, and also have a lot of roles in inhibition of the this synovial hyperproliferation and synovial pannus formation which occurs in the rheumatoid arthritis. Then is the local sprintage. Local sprintage is to actually deal with the joint subluxation. If there is too much tenosynovitis and ligamentous inflammation, there may be associated with joint subluxation, and patient may complain of giving way feeling of the knee joint. Therefore, knee brace or local splintage can be of effective therapy. Then comes the steroid injection. Steroids can be given in form of orally as well, and they are part of the treatment of the DMARDs, or locally injection of steroids are also a role, although it does not actually stops the development of rheumatoid arthritis. As you know, it's a progressive disease, but it does actually slows down the progression of the changes which is occurring in the knee joint. Therefore, steroid injection of the knee is one of the treatment before going for a big surgery. Then radiocolloids have a role as well, although its role is now being controversial or been limited as well, but it has been given in the past. That injection of hyaluronic acid and glucosamine have been given, and it has a role in both the rheumatoid as well as the osteoarthritis. But mainstay is the DMARDs and anti-TNF alpha inhibitors are anti-TNF medications, because mainly the interleukin 1 6 inhibitors and TNF inhibitors have actually given rheumatoid arthritis patients a new life. This has actually massively changed the way we manage the rheumatoid arthritis, and now the complications actually delayed for quite a long time, and patient's life is quite good enough to actually carry out his daily living on these medication only. And as a result, this progression which occurred in 3 to 5 years of time has actually been delayed to 10 to 15 years as well. Therefore, patients now develop less complications, and they progress towards the end stage disease much slowly as compared previously, which was about 30-40 years ago, which was not very much possible. Therefore, once the complication has happened, the problem is now there, and like it's maybe associated with massive arthritis. The bone may be damaged, there may be markedly reduced joint space, there may be a flexion contracture, or there may be actually like joint subluxation or dislocation may be present as well. Then comes the role of an orthopedic surgeon, that how to treat this complication. And complete treatment involves multiple ways of treating the disease. One is that you replace the joint, that is the arthroplasty. Orthoplasty is being routinely done nowadays for osteo as well as rheumatoid arthritis, and rheumatoid arthritis is usually a very common cause of actually going for a knee joint replacement surgery. And usually this leads, as it's bilateral disease most of the time, and therefore you may have to go for both knee arthroplasty, that is bilateral knee joint replacement surgery has to be done. Other is a sort of a treatment, but it actually is kind of a treatment. It's not very significantly treating a disease. It's like delaying the progress, as the role of injection steroids as well, that they delay the progress of the arthritic changes which develop in the knee joint. And that is doing the synovectomy and debridement. Because why synovectomy needs to be done? Problem started with synovial hyperproliferation and hypervascularity leading to synovitis. Therefore, the inflammatory process which is actually occurring in the synovium can be partially treated by using arthroscopic associated synovectomy and debridement. This actually does not completely cure the disease because the problem is autoimmune, but it sort of decreases the progression and changes from stage 1 or early changes to cartilage destruction, and then eventually leading to bony disorders or bony loss as well. Therefore, this synovectomy and debridement is sort of a way in which we can delay the changes in which occur in the knee joint for quite a long period. But definitive treatment with is actually on rheumatoid arthritis is knee joint replacement surgery. And what has happened over the last 4 or 5 decades is that these patients developed complications quite early. Their life, despite the treatment, adequate treatment, made quite miserable. But now with the advent of DMARDs, especially the role of anti-TNF alpha inhibitors and interleukin 1s, a lot of complications have actually been reduced. And usually these patients, when they do develop complications, this is quite after a very prolonged period of time. And usually they have been under the treatment for a rheumatologist about 10 to 15 years as well. So rheumatoid arthritis in a nutshell is an autoimmune disorder, systemic problem, would affect multiple other joints, and you need to rule out what are the other complication patient is having as well, especially in the elbow and the hand. But when it comes to knee joint, the mainstay of the treatment is always the medications, physiotherapy, and may require some conservative adjuncts like intra-articular steroids. But once the patient has developed complications, the mainstay of the surgical treatment of the rheumatoid arthritis is arthroplasty, that is the joint replacement surgery.